Good afternoon and welcome to this latest webinar from CumbriaMed and from the Pears Cumbria School of Medicine. I'm Jonathan Weber. I'm co-director of the Pears Cumbria School of Medicine Research Hub with my colleague, Professor Sophie Day. So PCSM is a new medical school in Cumbria and is a partnership between the University of Cumbria and Imperial College London, together with the NHS Trust, North Cumbria Integrated Care, NCIC, and University Hospitals Morecambe Bay. And the purpose of these webinars is to bring together scientists from across the universities, together with practitioners in Cumbria, to look at topical areas of medical research of interest, I hope, to a very broad community. So in this webinar today, we're going to be looking at routinely collected NHS data on health and how it can be used for specific research purposes. So without further ado, it's an enormous pleasure for me to introduce Professor Paul Aylin. Paul is Professor of Epidemiology in Public Health at the School of Public Health at Imperial College London. And he's had, as you will hear, an extraordinary career in looking at the uses of NHS data for research and other purposes. So, Paul, over to you. Thank you.
Brilliant. Thank you, Jonathan. Great pleasure to be here and rabbit on about my work. So first thing to say is that this is not a new idea of using hospital data. The great epidemiologist and statistician Florence Nightingale first suggested back in the 19th century that having hospital data would be really useful to make comparisons between hospitals and across different parts of the country and different conditions. So I'm just following in her great shadow. Fortunately, nowadays, we do have access to a lot of data, and I'm going to focus mainly on hospital data, but mention primary care data a little bit later on. And within England, we have an electronic record of every inpatient episode of patient care in every NHS hospital. This is some 19-20 million records a year, 300 fields of information, including patient details such as age and sex, diagnosis, procedure, admission methods, discharge methods. And there are also separate databases on outpatient, day case and A&E attendances. And these data de-identified are made available to researchers under strict conditions, kept on a secure server and only used for certain research purposes. But I've used them a lot over the years. And I first became involved in health service research, I guess you could call it, as a result of a couple of big NHS scandals. The first was a paediatric cardiac surgical unit at Bristol Royal Infirmary, and the second was Harold Shipman, the GP serial killer who murdered over 200 of his patients. So the Bristol Royal Infirmary, this scandal sort of brewed and arose out of rumours that were well circulating at the time of poor care at Bristol, and this, in particular, this paediatric cardiac surgical unit. And they were highlighted by Dr. Phil Hammond in the satirical magazine Private Eye. And he had a number of columns talking about this problem. And local GPs were very concerned, referred to the waiting rooms of this unit as the killing fields or the departure lounge or all sorts of things. So this problem had been well known about informally. The scandal involved a couple of surgeons, the lead surgeon James Wishart, the chief executive, who was also medically qualified, and was first broken within the unit by a very brave anaesthetist called Steve Bolson, who first did an audit, an internal audit on this, and found high mortality rates. Attempted to go to the hospital and alert them of this problem, but it was suggested that if he wanted to maintain a career in anaesthetics, that he shouldn't take this any further. Fortunately, he did, and after several attempts, managed to raise this issue with the Department of Health. And the Department of Health then carried out a local investigation. The GMC did an investigation, struck 2 of the clinicians involved off the medical register, and there was a big public inquiry announced, and we bid to do some work for the inquiry, looking at hospital episode data, and we published our paper in the Lancet. But the key finding we got from hospital episode data was that in the 12 surgical units that we looked at within England, the average mortality rate was around about 12% for these kinds of operations. So it's still pretty high. But in Bristol, Bristol was a clear outlier with a mortality rate of some 30%, which was more than double that of the national average. The inquiry, using some of our data and data from all sorts of other sources, found that there was inadequate care for a third of children. Mortality was significantly higher in comparable units. Internal concerns were raised. And the recommendations arising from this inquiry really changed NHS governance. It led to the founding of the what's now called the CQC, then the Healthcare Commission. And it also found, interestingly, that there was plenty of data around and people could have spotted these problems a long time ago, but nobody had bothered to look at them. Moving on to Harold Shipman, who has the distinction of Britain's most prolific serial killer, killed some 250 of his patients, possibly more. He was caught, arrested for the murder of one of his patients, Kathleen Grundy, who he had rather clumsily forged a will of. He was then accused of killing 15 of his patients, and he was convicted and sentenced to prison of murder for those 15 patients. But shortly after that, Alan Milburn commissioned a large public inquiry headed by Dame Janet Smith into how a GP could get away with killing so many patients without anybody noticing. And we were asked the question, could we have detected Shipman after by looking at the data alone? And so as part of this exercise, we were given data for over 1,000 GPs in 5 health authorities. One of those GPs was Shipman, but we were blinded as to which one. We had no idea which one he was. And we looked at methods for looking at data over time, sort of routine surveillance, to see whether we could spot Shipman. And we came upon a method called statistical process control charts, which are widely used in industry for quality control, but at that time had not really been applied to medicine. And these charts essentially consist of some function of your expected outcome. And in this case, we're looking at death rates, and your observed outcome. So we compare the number of deaths we would expect compared to the actual number of deaths by practice, and use a function of this figure, which is called the Q-sum statistic, and add it to the previous year's figure. If a practice has consistently high mortality, then this chart gradually increases and will cross an alarm threshold and will flag a problem. We looked at 1,000 GPs. We presented our results to the inquiry panel, and much to our relief, it turns out that this method can or could have detected Shipman at least 2 or 3 years earlier than when he was actually caught. But unfortunately, there were another 12 practices within that 1,000 practices who also alerted. There were various issues with those practices. Many of them had very high proportions of patients in care homes, and we weren't able, with the data that we had, to take that into account. Anyway, after that bit of work, we then started to apply this SPC methodology to hospital data. And we came up with a system that could monitor some 100 different diagnoses and surgical procedures by hospital on a monthly basis. And we were able to run these SPC charts each month for these hundreds of different processes, and flag those alerts, those processes which alerted on our system, and we wrote to the hospitals concerned. We started this in 2007, and in the first 8 months of running these alerts, there was one hospital which flagged more than any other, and so it flagged 6 times in that 8 months. And this was a hospital called Mid Staffordshire General Hospital NHS Trust. As I said, we wrote to the hospital. We didn't get any replies, but we also copied our alerts to the Healthcare Commission, as it was called at the time. They'd also had different concerns around Mid Staffordshire from different sources, and they decided to investigate emergency care in this hospital, and found really appalling standards of emergency care at this hospital. There are a number of inquiries arising out of this, culminating in this big public inquiry led by Robert Francis. And they confirmed that there were appalling standards of care at this hospital, and made numerous, hundreds of recommendations, not all of which have been followed, but certainly had a huge impact on how we monitor quality and safety within hospitals, although scandals are still occurring. We published that system over 10 years ago now. So on to a different topic now, and both these topics arose from my own personal experience as a junior doctor, as we were called then. And this first paper sort of reflected my experience as a junior house officer, as we are called now called Foundation Year 1 trainees. And that was, we all started on the same day in August, the first Wednesday of August. And I remember my first day in a completely new hospital, new system, completely new way of working. And really sort of there was a sort of urban myth at the time amongst junior doctors that this was called the killing season, that you expected that your first few weeks you would lose a few patients. But I wanted to see whether this was more than an urban myth and see whether the data backed this up. And so using hospital episode data, we decided to look at patients admitted in that changeover day, that first Wednesday in August, and compare them with patients admitted the previous week, and follow those patients up for 7 days so that their care didn't overlap, and do that for a number of years. And we looked at 9 years of data in the end, which gave us around about 300,000 patients. And we did, in fact, find a very slight increase in the risk of death in those patients admitted on that changeover day. And in fact, when you took account of the slight differences in the kinds of patients admitted on those days, maybe they were slightly older, slightly younger, different case mix, taking all that into account, we found around about a 6% higher odds of death for a patients admitted on the first Wednesday in August. This work did result in a number of recommendations and indeed changes to healthcare and the way junior doctors start, or resident doctors as they're called now. And all foundation year one doctors now have to undergo a period of induction and shadowing, which I must say I would have appreciated in my time as a junior house officer. And not all resident doctors now start on that same day, so there is some period of consistency. The other bit of work that I looked at, again, resulted from my own experiences as a junior doctor, and that is the difference in care between weekends and weekdays. I remember not being able to order various diagnostic tests. I remember one hospital I worked at, I was told I wasn't allowed to ask for blood cultures on a weekend because it would mean the microbiologist would have to come in, and he was a bit of a grumpy man and we didn't want to upset him. So there were sort of definite differences that I was aware of as a junior doctor at weekends compared to weekdays. And I wanted to see whether this was borne out in the data. So for this bit of work, we looked at 1 year of data. We looked at 4 million emergency admissions across England with over 200,000 in-hospital deaths. And we found around about a 10% increase in the odds of death if you're admitted at the weekend as an emergency compared to being admitted on weekdays. And we looked at a whole range of different diagnoses, and 17 out of those 50 diagnosis groups had significantly and statistically significantly higher odds of death. We published this paper in BMJ Quality and Safety. Eventually, we did have our paper rejected by the British Medical Journal, and interestingly, they rejected it on the basis that actually this effect was well known, and it wasn't adding anything to the literature. When we published in BMJ Quality and Safety, although maybe professionals, clinicians and the BMJ editors were well aware of this, the general population certainly wasn't. And it generated a lot of interest and headlines. We did a lot of follow-up work to that. So we looked at elective procedures. And there are not many elective procedures carried out at weekends, but our hypothesis was if you had your operation on a Friday, your post-operative period, where there were fewer staff around, may have a difference in terms of outcomes. And indeed, we did find this. So you can see, compared to Monday, as your operation approached the weekend, and particularly on a Friday, where your post-operative period occurred over Saturday and Sunday, you had a much higher risk of death, some 40% higher. And if you had your procedures at the weekend, even higher. As I said, we've looked at a lot of things. We've also looked at stroke. We've looked at maternity care. For stroke, we looked not only at the outcomes, but the processes of care. So we found not only did you have higher mortality if you're admitted at the weekend with a stroke, but you were also less likely to get a scan on the same day. You were less likely to have interventions like thrombolysis, or that's dependent on the kind of stroke that you had at the time. And this sort of weekend work had a huge impact at the time in terms of NHS moving to sort of 7-day a week services. There were lots of aspirations around doing something about this. It kind of got a bit caught up in industrial dispute between the junior doctors and Jeremy Hunt at the time, and since then not much has happened as far as I'm aware, but it certainly had an impact at the time. Interestingly, when you look at stroke mortality, and we did a follow-up paper to see what had happened with stroke mortality, particularly looking in London where stroke services have been reorganised. They were reorganised in 2010, and you can see not only a reduction in mortality in 2010, But you can see that this weekend effect, the difference between weekday and weekday mortality, essentially disappeared. Across the rest of England, that happened much slower in that bottom graph, but actually with less sudden sort of reorganization of services, that weekend effect has disappeared in stroke care. I just want to talk briefly about primary care. And there are several research databases which are able to look at primary care consultation. In Northwest London, we have the Whole Systems Integrated Care System, which has primary care linked to secondary care data. And we have done a fair bit of work looking at that data. And here's one example, looking at vaccination in pregnancy. And we were looking at uptake of both the influenza vaccine and the COVID-19 vaccine. And we found a variable uptake depending on age. The COVID vaccination had higher uptake than the influenza vaccination, which is really very poor, overall vaccination coverage of about 20%. But more importantly, we also found quite stark differences in vaccination rates by ethnicity, by socioeconomic deprivation. And we've been able to use some of that information to talk to the local ICB about how they can change their strategy in terms of vaccination rates. I just wanted to say a huge thank you to all these papers have vast teams of people working on them, and in particular Alex Bottle, who has worked very closely with me on practically all of these researches, Tom Woodcock, and in the past people like Azim Majid, Paul Elliott and Brian Jarman. And finally, just to say, research partly supported by NIH and Imperial Biomedical Research Centre, and the views expressed are my own and certainly not NIHR's. Jonathan, I think that might be 20 minutes exactly.
Thank you, Paul. It is exactly 20 minutes, and thank you so much for that presentation. So if you'd like to, that's it, perfect. And if I can invite Walter to put up his slides. So for the second presentation today, I'm going to introduce Dr. Walter Gutierrez, who is a postdoctoral research fellow at Imperial College in the School of Public Health. And Walter's been analysing NCIC data, looking at patient flow across Cumbria, given the extraordinary geography of Cumbria and the very dispersed population within it. Walter, thank you.
So thank you so much, Jonathan, for the introduction. And I'm going to talk very briefly about how we can use data from North Cumbria integrated care data, and to understand a little bit more how is the patient flow in the different service in two services in Cumbria. So very concisely what we did was use routinely collected data to understand the service demand and accessibility, and as well to try to understand what could happen if these services were reorganized. In order to do this, we use hospital episode statistics, which Paul already talked about. And we use in particular the data that contains the admitted patient care, so those patients that are admitted to the hospital, as well as the data set that collects information on A&E, so emergency care data set. And we also use information publicly available from the Office of National Statistics, such as the Open Geography portal, and data on road networks from the OpenStreetMap to use in order to estimate or calculate journey times between different points of North Cumbria and the hospitals. And we put together these pieces in order to try to get a picture of what is the state of patient flow right now in North Cumbria. More precisely, what we did is use that data to look at time series analysis, to look at how seasonality and trend, so basically how it changes during the year and what is the overall trend that we're looking in terms of service utilization. We also wanted to see the geographical patterns with the spatial analysis, so how they are distributed across the area. And as I mentioned, we use information on roads in order to estimate journey times between different parts of Cumbria to the hospitals. And we also explore what could happen if there were some service reconfiguration or reorganization scenarios, and in particular focusing on how this will affect the journey times of people attending to the hospitals and how that can have effect on accessibility. So why this matters? Well, as I'm pretty sure most of you are aware, so Cumbria Integrated Care, the trust serves about over 300,000 people or residents across an area of 2,600 square miles. And there's a lot of rural communities in this area. And as you can see, we have islands of urban areas surrounded by rural areas with various degrees of accessibility, especially in areas surrounding Carlisle or Penrith, but in parts of the coastal areas around Whitehaven, we also have a little bit of a patchwork between large rural areas and urban areas that are not as well connected. So this has different effects in how people can access health services. And there's obviously some population changes that the area, England as a whole, but the area in particular, is experiencing, where we have a population that is aging, and as well the population where younger individuals are kind of aggregating around urban areas, while we have all elderly people staying in the more rural, less well-connected areas mainly. So we studied two critical services, maternity and emergency care. For maternity services, we look at those in Carlisle and in Whitehaven, as well as the birthing unit in Penrith. And for emergency care departments, we look at the major units in Cumbrian Infirmary, West Cumberland Hospital, as well as the urgent treatment centers in Penrith and Keswick. So what we found, some of the key findings that we found with our analysis is that, first of all, we can have a look at how the service utilization has varied across time from 2015 to early 2024. And the red line that we can see here is the one that shows the overall trend, so how it's the average change over time. And we can see that the gray line that kind of zigzags around it is some of the variation that happens across seasons or across months, and that has certain periodicity during the years. And as we can see is that for all deliveries in maternity services, there's been overall decrease. So about a decrease of about 13% from early 2015 to 2020 to early 2024. However, if we just look at the subset of these deliveries that are cesarean sections or C-sections, we can see that despite of them being overall lower numbers, the proportion or the number of C-sections is actually increasing to the point that in terms of total numbers from the beginning of 2015 to early 2024, there's been a 40% increase in the number of C-sections or cesarean sections. If we look at the geographical patterns between the service provided by Cumbrian Infirmary and West Cumberland, we can see that there is this very interesting and marked northeast southwest divide, where those that are in the northeast, sorry, they tend to be aggregating or attending to the maternity unit in Cumbrian Infirmary, while those that are located in the West Coast, in the coast, they tend to go to West Cumberland Hospital. And I thought there is some slight overlap. We can see that these two centers, they do serve very specific areas or regions of Cumbria. And we look if there, and the overall, broadly speaking, the overall obstetric risk is similar in both units. So it's likely that one of the main drivers, at least from what we can tell, is accessibility, and perhaps some other factors that we cannot quantify so easily as is patient preference. Looking at what we found for emergency services, we have as well, once again, we see that there is an overall trend with some seasonal variation. And we can see that the number of visits to emergency services in general across the region has increased about 40% when comparing from June 2018 to early 2024. And we can also appreciate some peaks in seasonality that occur during the summer months. This is likely due to the increased tourism that the area sees, and that means that during these times there's going to be increased demand for emergency care services. We also look at how the demand varies across the week. So we have basically like a week calendar split by time period, and as we can see, the biggest demand occurs across the week between 8 in the morning to 8 in the evening. And there is a particular high demand that occurs during Mondays during this time, and in particularly between 8 and 4 p.m. And as we can see, the spatial distribution or the geographical patterns of service utilization for the major emergency units shows a similar pattern to what we see for maternity units, with the highest demand occurring in the areas that are surrounding the major the major units. I thought there is a more widespread use from several parts of Cumbria attending to the emergency departments. And when we look to the urgent treatment centers, we can see that they have a far more local or localized usage, or from people that are very local to the unit. So they serve a very important purpose for the local area. In terms of journey times, we found that access is often reasonable, but there's going to be disparities, as we have seen that there is different areas of urban and rural across Cumbria. And in general, we can see that for maternity services, 50% of people can arrive within 13 minutes, and more than 60% of women using maternity units for deliveries can reach within 20 minutes. For emergency care, the median travel time was 11 minutes, and more than 2/3 of patients could access emergency services within 20 minutes. But there is the caveat that for estimating these travel times, we have used sort of the ideal conditions. So we are not accounting for roadblocks or road work or something, or natural disaster that may impede the journey of patients traveling to the different units. And we can see that the rural communities, I thought this is kind of the that patients can access reasonably. Patients in rural communities are going to be or are facing much longer journey times than urban ones. And it's also important that the longer the journey as well, that there is more likelihood for there to be some issue that hinders traveling. And when we explore what could happen in several scenarios of service reconfiguration. I'm not going to be going one by one. I'm just interested in showing you the general pattern that we're seeing here. So we have we have different travel time bands, and we have the percentage of people arriving within that travel time bands. And in blue, the blue numbers and the blue dots, they represent what it's been observed right now, what's the current reality. And then we have also the red dots that represent what would happen in the case of each simulated scenario. So for example, if we were to redirect patients from West Cumbria Hospital to Cumberland Infirmary, we can see that the general pattern is that the percentage of patients arriving timely to the unit decreases, while the number of patients arriving later greatly increases. So there is this peak, and this pattern of those arriving early getting reduced and those arriving later getting increased is consistent for in all the scenarios, perhaps to different degrees, but in all the scenarios we can see that if we reconfigure either maternity or emergency services, we're always going to see this important increase in those in patients arriving late, and a lower proportion of those arriving in timely manner. And this seems to be especially problematic for those living in the outer areas of Cumbria. So based on this repeated pattern that we saw in different of the scenarios that we simulated, the conclusion that we can reach is that centralization of services is going to increase the journey times and reduce accessibility for patients requiring these services. And this is going to be especially for those residing in rural areas or those that have to cross through rural areas to reach the services. And just to just some take-home messages of our key findings is that we have declining maternity volumes, but with a relatively increase in C-sections. We are also observing an increased demand for emergency services, and there is a seasonal component, an important seasonal component during summer, representing increased tourism to the area. We have some while most patients can reach at least in optimal conditions in adequate times, there's still inequalities in accessibility to services, especially for those living in rural areas, which due to population changes are likely to be older or elderly individuals. And once again, after looking at different scenarios of service reconfiguration where services get centralized towards a particular site, we see that this centralization or redirecting patients is going to have a great increase, and it's going to delay people from reaching services timely. And this is going to particularly affect those that are already living in rural or faraway areas that are already having trouble accessing the service or reaching the services on time.
Walter, thank you very much. And it really shows extraordinary power to look at routinely collected NHS data to analyze that alongside a completely different data set, looking at travel and how we use our roads. So thank you very much indeed. So I thank both the speakers very much. Thank you all very much for attending. Thank you, Paul and Walter, and I hope we'll see you all in 4 weeks' time. Thank you.